This hearing will now come to order. And I will now turn the hearing over to Ranking Member Moran for his opening remarks, and then we'll proceed with introduction of witnesses.
Already this is moving more smoothly than when Senator Tester is here.
This is true.
Thank you very much, Senator Hassan, and thank you to our panelists, and thank you to Senator Tester for calling this meeting. Good afternoon to all of you. We have a full list of bills to consider this afternoon, and I look forward to hearing about each of them and how they will improve the care that veterans receive. I continue to hear from veterans in Kansas and across the country who face what are unacceptable barriers to accessing timely, quality health care that they need. For example, we heard from one veteran who called the Veteran Crisis Line in 2021 and is still waiting for the VA to call him to schedule a follow-up mental health care. We heard from another veteran who paid several $1,000s for dental care outside of the VA because the VA dental exam room could not accommodate her wheelchair. The VA has refused to issue her a community care referral. We heard from yet another veteran who asked for a referral to a rehab program at a non-VA facility in his rural community that had opening for him, but was told to wait several weeks for a bed at a VA facility in another state hours away. These are just 3 stories, but they are alarmingly common. I've always told people that what I know about what's going on at the VA and what's going on in veterans' lives is by the conversations I have with Kansas veterans, and these are stories that they bring to me. I've introduced a couple of the bills that are on today's agenda as a result of those kind of circumstances. S. 1315, the Veterans Health Empowerment, Access, Leadership, and Transparency for Our Heroes Health Act, would codify the current community care access standards, educate veterans on their rights to seek community care, hold the VA accountable for providing timely access to care, and help the VA keep pace with the best practices for modern medical care in DOD, CMS, and the private sector. The Veterans Health Act is bipartisan, and I appreciate my colleague Senator Sinema for working with me on this legislation. This bill is also widely supported by veterans organizations, including the American Warrior Partnership, and I'm grateful to Jim Lorraine, who we will hear from on the second panel. He's the President and Chief Executive Officer of AWP and will testify shortly. And because no healthcare system in the 21st century can provide world-class services without a safe, top-notch IT system, S. 1037, my VA Electronic Health Records Modernization, Standardization, and Accountability Act would establish a clear and consistent set of safeguards that must be met before VA can move forward with implementing the new Oracle Cerner electronic health record. Ultimately, this bill facilitates a more thoughtful and evidence-based implementation, increasing the likelihood of success and improved patient outcomes in the long run. Chairman Tester has bills on today's agenda that are similar in certain ways to both of these, the Veteran Health Act and the VA Electronic Health Record Modernization Act, which suggest to me that we can find a path forward working together. I look forward to working together with all my colleagues on this committee and in the Senate as we work to negotiate strong, bipartisan, and fiscally responsible legislative package that contains the best of our bills and the many others that we will discuss this afternoon. And I thank you all for being here, and I yield back.
Well, thank you, Ranking Member Moran, and I will note, too, that there is obviously a lot of bipartisanship on this committee, and as we hear about pending legislation today, I look forward to finding ways we can all work together. With that, I want to welcome the first panel to today's hearing. Dr. Miguel Lapuz, Assistant Undersecretary for Health for Integrated Veteran Care, will be VA's lead witness today. He is accompanied by Dr. Matthew Miller, Director, Suicide Prevention Program, Office of Mental Health and Suicide Prevention, Dr. Cynthia Gant, Deputy Director of the Office of Patient-Centered Care and Cultural Transformation with Patient Care Services, and Dr. Leslie Sophocleous, who is Executive Director for the Integration Office. Dr. Lapuz, please begin.
Good afternoon, Senator Hassan, Ranking Member Moran, and members of the committee. I appreciate the opportunity to discuss VA's views on pending legislation regarding health care benefits. I'm accompanied today by Dr. Matthew Miller, Executive Director of VA Suicide Prevention, Office of Mental Health and Suicide Prevention, Dr. Cynthia Gant, Deputy Director of Patient-Centered Care and Cultural Transformation, Office of Patient Care Services, and Dr. Leslie Sophocleous, Executive Director, Program Management Office, Electronic Health Record Modernization, Integration Office. There are 19 bills on the agenda today covering a range of issues and programs. My written statement provides more detailed information on nearly all of these bills, but I would like to take a few moments to raise some issues of general applicability to these bills, and particularly for the Veterans Health Act and the Making Community Care Work for Veterans Act. While we agree with the spirit of improving access and delivery of care to all veterans, there are several provisions in the aforementioned bills that VA does not support because statutorily mandating these efforts would impede VA's ability to furnish clinically appropriate and timely care to veterans. Nearly 6 years ago, a predecessor of mine sat before this committee and articulated a few principles of VA believed should be reflected in legislation that would ultimately become the VA Mission Act of 2018. One of these principles was the idea that VA needs to retain flexibility to adjust and adapt to an evolving healthcare landscape. Legislation that is too prescriptive in terms of rules, responsibilities, or processes can only limit our options in the future, which would lead to frustration from our veterans, our community providers, and VA employees. We believe that the best legislation would provide broad, general authority that VA could define and implement through regulations, policies, and contracts. These themes still ring true today. The Secretary and the Undersecretary of Health have made ensuring veterans receive timely, appropriate, and accessible care a top priority. Each veteran's needs are different, and to best serve veterans, we need the flexibility to respond to those needs. Regarding the 2 electronic health record modernization bills, VA is committed to continued improvement of this program, and we are keeping you and your staff and key stakeholders informed of these efforts. Healthcare, and particularly healthcare information technology, is dynamic and needs to be responsive to veterans and clinicians' needs. We strongly caution against enacting requirements that may address today's situation, but could create unintended outcomes in the future. VA appreciates this committee's willingness to engage on these bills. There are many examples of where these efforts have borne fruit, including the Expanding Veterans Options for Long-Term Care Act. We look forward to discussing VA's perspectives concerning the bills on the agenda, and we would welcome the opportunity to continue collaborating on how we can improve delivery of care and services to our nation's veterans and their families. We thank the committee for its continued support, and this concludes my statement.
Well, thank you very much. I think we can proceed to questions from here. I will go ahead and start, and then Senator Moran, you can follow. And I want to again thank all of our witnesses, not only for being here, but for your work and for the teams that you lead on behalf of our country's veterans. Dr. Lapuse, I want to start with a question that highlights a Granite State veteran and his service dog, Duchess. Tim Kerrigan of Lyman, New Hampshire, reached out to my office last year because he was having difficulty obtaining insurance coverage for Duchess, his service dog, through the VA, something that the VA does for veterans. My office was able to coordinate with local and regional VA representatives to fix the problem. The insurance coverage was made possible through the Puppies Assisting Wounded Service Members for Veterans Therapy Act, known as the PAWS Act, a bipartisan bill that I co-sponsored and Senator Tillis introduced that passed into law in 2021. Now I am joining Senator Tillis and colleagues to support a follow-up bill that would further expand access to trained service dogs for veterans. Can you talk about how the VA coordinates between healthcare providers and nonprofit organizations that train service dogs to ensure that veterans who need them can receive service dogs as soon as possible?
Ma'am, in reference to the service dogs, we are in the process of developing in VA the opinion on how we're going to proceed with that. So I apologize for not being ready to discuss that at this point.
Well, I appreciate that. Let's follow up with the conversation because this was passed in 2021. We know how useful service dogs can be for our veterans, and something like this barrier that prevented requisite insurance for the dog made it hard for this particular veteran to get that kind of service. And we're seeing more and more training efforts to get the dogs to veterans. And so I hope you will treat it with some urgency, and I'd look forward to working with you on it.
We understand, Senator, and we look forward to having a discussion with the committee.
Okay, thank you. Second question for you, Doctor. The VA provides veterans with numerous benefits and different types of care, but veterans seeking health care may not be aware of the other benefits and wraparound services that are available to them. These wraparound services could include things like transportation, food or housing assistance, and various support groups. Today, I joined Senator Sullivan in introducing the bipartisan Leveraging Integrated Networks in Communities for Veterans Acts, which aims to improve the VA's ability to coordinate across these different services. So how can Congress and the VA work to facilitate better coordination for getting veterans wraparound services?
We appreciate your concern, Senator, regarding wraparound services, particularly those that will more or less address the socioeconomic determinants of health. And we have a program in the VA which is already assessing the requirements of our veterans in order to ensure that they have services that will customarily not be available, and we call that initiative ACORN. We have already 5,000 veterans that have already been, that have gone through that process. We can have a conversation with the committee regarding the progress of ACORN, but the reason why we feel that this is a redundant, the legislation is redundant in terms of what the VA is already doing, and we are hoping that we can share with the committee the results of these, and so before we actually have any legislation. So we're looking forward to having a discussion regarding the existing programs that already are addressing the socioeconomic determinants of health.
Well, I appreciate that, but again, this is about getting those full wraparound services that are already out there and making sure that that our veterans get them. So I'd look forward to talking with you more about that, but in my experience, sometimes until we pass legislation, we don't get the full scale of services that we're looking for. So let me just finish with one more question. Another example of the need for the coordination that we were just talking about is that often a veteran in New Hampshire, which as you know doesn't have a full service VA hospital, will be seen at a local hospital for urgent health concerns, but that hospital may not have the experience needed to coordinate care through the VA. As a result, the Manchester VA Medical Center in New Hampshire recently began embedding a VA care navigation team at one of the nearby hospitals. I believe this model could help other facilities connect veterans with wraparound services as well, and the Link for Veterans Act, the one we just referenced, aims to do that. How could care navigation teams like the one at Manchester help veterans across the country access wraparound services?
We have learned from the experience in Manchester that you were referring to, Senator, and in fact, we have several pilots that are mimicking what is happening in Manchester, and this is in our coordinating and optimizing emergency department care as part of that initiative, which is what we refer to co-ed initiatives. So we're hoping that we are going to learn from all of the pilots that are happening across the country, because we do have several hospitals in Pennsylvania, for example, that are doing exactly similar initiatives that you have referred to in Manchester. So with that, we will learn in VHA how to proceed to ensure that we do have wraparound services, particularly for those who have been admitted to non-VA hospitals.
Well, let's keep working on that together, and I appreciate very much the work that you are all doing. Senator Moran.
Thank you, Senator Hassan. If Senator Tuberville would like, I would be happy to yield to him to ask questions.
Let's do it. Thank you. Thank you. Thanks for the witness being here today to talk about this pending legislation. Very important for veterans all across the country. Dr. Lapuz, I co-sponsored Senator Blackburn's Veterans Healthcare Freedom Act because I support veterans accessing the doctor of their choice, whether the doctor is at the VA or in their community. I understand frequently the veterans enrolled in the VA healthcare are not educated on the access to care in the community. Well, the VA has taken the position to oppose this legislation, the fact remains that the Mission Act gives eligible veterans the right to access community care. Doctor, what trainings have the VA providers undergone to ensure they are open with the veterans on their eligibility for community care? Any training that's going on?
Yes, Senator. We have trained every one of our schedulers. It's a rather extensive training to ensure that the schedulers have a good understanding of the eligibility for community care. So we have extensive training for that, Senator.
Are you getting good feedback from that? Do you know? Have you?
And generally, in this, our schedulers are able to perform quite well in their jobs, and that is, we do have a lot of dedicated employees that are performing to the best of their ability, and majority of the time that they're able to inform veterans regarding eligibility in community care appropriately.
Do you know of any post-appointment surveys that we do to get their feedback from the veterans after they've been to the VAs?
Not to that question, Senator, but we have V-Signals, which is like a survey after a veteran has visited our clinic, as well as after a veteran has visited community care clinics. So we do have the feedback regarding the care that they have received, whether that's in-house or in the community care.
Yeah, and that's the best way to get better, is to find out what you did right and what you did wrong.
Yes, sir.
Dr. Miller, as you know, Operation Deep Dive conducted by Duke University and America's Warrior Partnership requires information from the VA that is vital to their analysis on veteran suicide rates across the country. You know, what information has the VA provided to America's Warrior Partnership so far, and what additional data does the VA plan to provide?
Thanks for the question. There's been a rather extensive history of correspondence and dialogue with AWP and Operation Deep Dive regarding this issue. Be happy to present the full history documentation to you, including present state and planned future state.
You think it's working, getting that data? Is it helping? We learning from it? Do you know of?
I think what we're learning, and this gets to the more than just a number act, I think that what we're learning is there's room for improvement in terms of data validity and speed coming from states and coming into the federal network. And therefore, you'll see us supporting stipulations within the more than just a number act.
Does the VA have concerns about sharing this data with other people? Is there concerns?
By this data, I would probably need more specifics to answer that specifically. However, we do protect veteran data to the fullest extent possible for the benefit of veterans and for the mission. Now, within that, then, we also seek to be as transparent as possible to promote the mission, which includes partnerships with other collaborators, such as AWP.
Thank you. Dr. LaPuz, among many things, the Health Act would allow veterans experiencing substance use disorder to access care in the community without first receiving a referral from the VA. Testimony states that the VA cannot support codification of residential treatment and rehabilitation services as proposed in this bill, and that the VA generally supports establishing a wait time standard of 10 or fewer days for the delivery of such treatment and services, although the VA opposes codifying this timeline in law. Given that veterans experiencing substance use disorder require help immediately, why does the VA want to keep bureaucratic red tape in place before a veteran can get help?
So Senator, just like any other treatment modality, there is a requirement to fully assess the veteran and have an idea of how you're going to meet the veteran's need. And this is just a part of the clinical requirements. So we would like to make sure that, that we have a very good assessment of the veteran's needs before we actually have a remedy for that kind of condition, and that includes substance use disorder. So in our minds, we would prefer that for the VA to actually maintain that flexibility so then we can make sure that there's appropriate clinical determination of the veteran's needs.
Yeah. Why is the VA opposed to codifying a wait time standard for rehabilitation services? Why are we opposed to that?
The codifying the standards really limits the authority of the Secretary to determine what is required for veterans care. And we all know that the healthcare landscape changes, and it is important to the VA for the Secretary to maintain that authority, to make a determination on what will be needed in order to take care of veterans' needs at that particular point in time.
Thank you. I apologize, Madam Chair, for going a little long. Thank you.
Thank you. Senator King.
Thank you, Madam Chair. One of the bills before the committee today involves the reimbursement for domiciliary care for veterans with dementia. And this is something that Maine Veterans Homes undertook. On January 5th, 2021, the President signed the Johnny Isaacson David P. Rowe Veterans Health Care Act. It had in it, Section 3007, the VA to allow a waiver for eligible veterans to receive per diem payments for domiciliary care. So far, so good. January 5th, 2021. As of today, no rules have been issued by the Veterans Administration to implement this law. This wasn't a suggestion from the United States Congress. This was a law. And we are still waiting. So I have a bill in before this committee that would mandate that the rules be issued. The Veterans Administration, for reasons that escape me, are opposing this rule. That takes a lot of nerve. Just issue the damn rule. And you know, if you're going to issue the rule, do it. Otherwise, we're going to pass this bill. But it's a damn shame that we have to pass a second bill to implement a bill that we already passed. So what's the problem here?
Senator, VA is not supporting this bill because we are actively, as you mentioned, working on the regulation.
Define active? Is that's 2021. Let's see, we're 2.5 years later. That's not very active.
And
Eisenhower retook Europe in 11 months.
yes, sir.
So active? Are you active? When give me a date.
I can't.
August 1st?
I cannot give you a
September
date
1st?
today.
Well, I guess we're going to have to pass the bill.
I will say, Senator, we are continuing to coordinate with this, as you know, the state veterans homes also, to make sure that piece, and we absolutely do support this type of care, making sure that we have this and we have the coordination that's required with
I'm
the state
delighted to
veterans.
hear that, and I'm delighted to hear about the coordination, but the veterans homes, the DAV, the VFW all support the bill that I'm talking about in order to move your agency to issue the rules so that we can give the veterans the care that they deserve. So, as you can tell, this is not acceptable. And so you said actively, I'll take you at your word and consider that a commitment to move on this matter in the immediate future, and that means in the next several months.
Yes, sir.
Agreed?
Yes, sir.
Thank you. Thank you, Madam Chair.
Thank you, Senator King. Senator Moran.
Thank you, Senator Hassan. Thank you, Senator King, for highlighting the challenge that we have even when we do pass laws. And Dr. Lapuz, I hadn't planned on speaking about anybody else's legislation, but the suggestion that we don't want law because it changes so quickly. I mean, you could say the same thing. You don't want rules because tomorrow may be different. Congress has a responsibility to give direction to the VA. We do it based upon our best abilities and the information that we have. And I find it, offensive isn't the right word, but it saddens me that a bill that, even if you support it, you don't want the Congress to be giving you directions. It's a significant part of our responsibility on behalf of those we serve. Let me ask you, Doctor, I've heard a lot of recently from the VA about the need for timely medical documentation from community care providers. I could not agree more about the importance of that, and there are challenges with how we communicate between a community care provider and the VA. I want to highlight an issue that just arose yesterday. My staff spoke to a longtime VA community care partner in Pennsylvania who has repeatedly been advised by the VA to send medical records information to a fax machine. It turns out that that fax machine is not monitored. This provider at the VA's instruction is sending medical documentations containing personal health information over and over again because there's no one else at the other end of the line. And in addition, those documentations, let me just first say, I'd like for you to commit that you'd work with my staff to solve this issue.
Yes, sir, absolutely.
Thank you. This provider is also being told that the VA will not send subsequent referrals to them because they are not returning medical documentation in time. And the VA is actually calling veterans who are actively receiving care from this provider to advise them to stop going, to stop obtaining their ongoing treatment, and to use VA telehealth services instead. More concerning, same provider shared documentation of a VA employee sending personally identifiable information, including dates of birth and full Social Security numbers, for veterans via unencrypted mail without taking even the basic steps to protect that information from disclosure. If a community provider had done this, it would have been grounds to remove that community provider from the network and lots of other serious repercussions. Again, the Veterans Health Care Act that I described in my opening remarks is trying to put a stop to this kind of conduct by improving how community care programs are administered. Will you assure me that the behavior that I described does not align with the standard of practice and work with my staff to look into these allegations and see if we can't put an end to them?
Yes, sir. We will work with your staff in order to look into this circumstance.
Thank you very much. I yield.
Senator Bozeman.
Thank you, Madam Chair. Dr. Miller, veteran suicide prevention continues to be my #1 priority, and I think that is true of a lot of people on this committee. I believe that the issue is more complex than just viewing it from a clinical perspective. There are other root causes of suicide we need to be looking at, such as food insecurity, lack of housing, and financial strain. That's why Senator Tester and I teamed up to introduce the Not Just a Number Act, which would allow us to study this issue from a holistic standpoint in order to better understand why veterans are taking their life. Dr. Miller, do you think that it would be helpful to move the Suicide Prevention Office from VHA to the enterprise level at VA to allow for better communication and data sharing between VHA and VBA?
Thank you, and happy to answer this question, and also want to express appreciation from the perspective of the suicide prevention team for your advocacy for veteran suicide prevention. What I think that you've done through this bill is you've demonstrated the importance, as you stated, of including important information and data within the analysis of veteran suicide. You have also further, I think, highlighted that that's going to require a deeper and broader level of cooperation and collaboration between VBA, VHA, NCA, and other federal agencies as well as states. 100% agree with you on that level. You then bring that into a conclusion in Section 5 saying, is suicide prevention organizationally placed well to implement Sections 2 and 3 in the manner that we're outlining here and we believe need to move. We think it's a fair question. We think it's a good question, and therefore we 100% support the feasibility and advisability analysis that you've requested.
Very good. Dr. LaPaz, you mentioned in your testimony that suicide is a rare event with no single cause, which leads me to believe that you would agree that there is no single cause to suicide. Then I'm sorry, what I'm saying is, is that there is no single cause to suicide, then there is no single solution as well. You go on to state in your testimony that the analysis required by this bill would only identify correlations and not causations. Wouldn't you agree that understanding the correlation between the VBA programs that prevent veterans from taking their lives is a good thing to know?
Senator, I will defer to our expert, Dr. Miller, to respond to that question.
Thanks. Appreciate the question. And the answer to the question is yes. It's important to study VBA-based efforts as well as VHA efforts and efforts that go into our community-based interventions program. Do what we can to validly study relationships between them and move the field and the VA closer to understanding what works, what doesn't work as well, and what's worth investing in from a program perspective.
So again, that's exactly what we'd like to do. In this bill with Senator Tester, our intent is to identify the programs that are working in order to better resource them and identify the programs that do not work so that we can modify them and be more supportive of veterans in need. So are we on the same page?
We're 100% on the same page, sir. I think the spirit of that particular feedback was not to indicate we are on a different page with you on this. It was more to indicate there are some complexities with relationships, and we'll move together with you to explore those.
Good. Thank you. Thank you all for all of your hard work. We appreciate you.
Well, thank you very much. Seeing no other questions for this panel, thank you all very much for your testimony and for your work, and I'll welcome the second panel to the witness table. Good.
I told her that this would be a great meeting without Tester. I was like, please, we ought to make this permanent.
6 years in the New Hampshire State Senate where you did a little bit of everything.
Yes, and actually did something.
You know, all votes in the state Senate, in the legislature in New Hampshire, all bills have to have a hearing. All bills get a vote, and even if they're voted down in committee, they go to the floor for a vote.
Really?
Yeah. So, yeah, it's straightforward. You know. All right. So, well, good afternoon to our second panel. It is good to see you all. We have John Retzer, Assistant National Legislative Director for the Disabled American Veterans, Megan Thomas, Associate Director, National Legislative Service, Veterans of Foreign Wars, and Jim Lorraine, President and CEO of the American Warrior Partnership. We are very grateful that you are all here today, and we look forward to your testimony on this pending legislation. Mr. Retzer, why don't we start with you?
Madam Chair, Hassan, and Ranking Member Moran, and other members of the committee. Thank you for inviting DAV to testify at this legislative hearing. We appreciate the many beneficial pieces of proposed legislation on agenda today to improve services for our nation's veterans, in particular our service-disabled veterans. My oral remarks will focus on the community care bills under consideration by the committee. Both S 1315 and the Health Act, the draft bill making community care work for Veterans Act, make numerous changes to VA current community care program. DAV supported the VA Mission Act after working with the committee and others to carefully craft a compromise to improve access, quality, and veteran-centric care, particularly those living in rural and remote areas, focusing on the key principles. First, ensuring VA would continue to be the primary provider and coordinator of veterans care, increasing VA's internal capacity through investments in staffing, infrastructure, and IT to meet the rising demand for care, establishing access and quality standards taking into account wait time and travel distance to care, and finally, requiring community care providers meet the same access and quality standards as well as training and certification requirements as VA clinicians. Both bills would codify the existing VA access standards for wait and travel times and would limit VA's ability to modify those access standards in response to changing conditions. DAV supports responsible efforts to lower wait and travel times for care. However, codifying access standards by itself will not improve veterans' access to care, lower wait times, improve quality, or to produce better health outcomes. We believe investing in the VA healthcare infrastructure, staffing, and IT would achieve these important goals. Furthermore, studies continue to confirm that VA healthcare is equal to or better than private sector care on average. And a robust VA healthcare system provides vital research, training, and emergency preparedness for veterans and the nation, furthermore justifying such investments. We have questions and concerns about the provision in both bills that would restrict the ability of the Secretary to review the best medical interest decisions between veterans and the referring physicians, which would limit VA's role in overseeing and meeting VA's quality care guidelines versus veterans' preference. DAV supports provisions in making the Community Care Work for Veterans Act, which seeks to expand VA capacity by increasing recruitment and retention programs for critical health care provisions. We support provisions seeking to increase training and compliance by community care providers. However, we strongly believe they should be required to meet all the same training requirements as VA providers. We also support the provisions to expand reporting of quality matrix by community care providers. However, the Secretary should set those standards. Further, we support the provisions to ensure community care appointments are scheduled more timely. DAV has questions with the provision in S 1315 to mandate the conversion of VA healthcare into a value-based care model. Given the medical complexity and the needs of the VA patient population, we recommend further studies, including eliciting an opinion from the Secretary's Special Medical Advisory Group regarding the use of a value-based care model in the VA healthcare system. DAV welcomes the opportunity to work with the committee to address concerns raised in these two bills and to develop a balanced bipartisan package to improve access and quality health care for all enrolled veterans. Our final comments are on S 1545, the Veterans Health Care Freedom Act. DAV opposes this legislation as it would unravel the Mission Act by completely eliminating access standards for community care eligibility. Although similar bills in recent years have been scored by CBO to cost billions of dollars, this legislation would provide no additional funding and would weaken the VA's internal capacity to care for enrolled veterans. Ultimately, it would threaten the viability of the VA healthcare and, more importantly, severely limit options of millions of veterans who have chosen and rely upon VA for care. VA is a unique healthcare system serving millions of ill, injured, and disabled veterans every year. We must ensure we continue to fulfill the mission in the years ahead, and we look forward to working with the committee and to find solutions that will improve access, particularly for rural veterans, while maintaining quality. We also believe the community care framework established by the Mission Act is the optimal path forward to achieve those goals. And now that Chairman Tester is here, Chairman Tester, this concludes my statement. I'm happy to address questions you or members of the committee may have.
And there will be questions, and thank you for your testimony. John, on behalf of the disabled American veterans, we appreciate always what you have to add to this committee. Next is Megan Thomas, who's Associate Director of National Legislative Service of the Veterans of Foreign Wars, otherwise known as VFW. The floor is yours, Megan.
Thank you, sir. Good afternoon, Chairman Tester, Ranking Member Moran, and the members of the Senate Committee on Veterans Affairs. On behalf of the VFW and its auxiliary, thank you for the opportunity to provide our insights on this proposed legislation. The VFW strongly supports S 928 that incorporates VBA data into its suicide prevention efforts. It is one of our top legislative priorities for this Congress. VA's suicide prevention efforts should include full information on disability compensation, use of education, employment, and home loan benefits, foreclosure assistance, and participation in housing and food insecurity programs. VA has recently begun reporting on the convergence of VA benefits and veteran suicide, but not in any substantial manner. We must identify, study, and utilize information regarding economic opportunity benefits and leverage that information to successfully prevent suicide among veterans. All veteran economic programs are administered by VBA, but the Office of Suicide Prevention is operated out of the VHA. We strongly support this proposal to begin actively incorporating data and benefit usage into overall suicide prevention efforts within VA. We also believe this should be a program under the Office of Secretary that would elevate suicide prevention as a top priority across the entire department and not only within VHA. VA's focus should remain on how veterans can receive the care they need, whether it is inside or outside of its facilities, which is why we support both Senator Tester and Senator Moran's community care proposals presented here today. The VFW sees many important provisions in both the Veterans Health Act and Making Community Care Work for Veterans Act that would both benefit the community care network. We encourage the committee to work in a bipartisan manner to take the best parts of both bills and combine them into a comprehensive community care bill that provides improvements that will help VA and the veterans that it serves. That said, there's one part of S 1315 we believe should be clarified. Section 103 may provide contradictory guidance to patients or clinicians regarding a veteran's preference for care. Currently, if a patient and the referring clinician agree to receiving care and services through a non-VA entity or provider would be in the best interest of the veteran, then they are referred to the community care. We are concerned this proposed section has the potential to allow contradictory guidance with the veteran's preference and the best medical interests. And there are certain sections of the Making Community Care Work for Veterans Act of 2023 we would like to see highlight as critical improvements, and other sections we believe could benefit from additional improvements. In Section 107, the VFW understands the need for self-referrals for services that are ongoing to remain constant care, remain a constant for the veteran. We would like to see additional services added to this list to include podiatry, prosthetics, laboratory services, dermatology, and the diabetes clinic. Services that are a part of a veteran's treatment plan should not have to be reauthorized if it's for chronic care and often utilized. In Section 112, the VFW supports a feasibility study to consider if community care network as a viable option for care in the Philippines. However, veterans in that area currently utilize the Foreign Medical Program, which is in dire need of improvement. The FMP has no formal means through which either veterans or providers can receive consistent reimbursement. We recommend providing structure to the FMP like VBA's compensation and pension overseas examination contracts and TRICARE overseas to include electronic reimbursement for care. Finally, an issue we would like to see addressed is veterans who are referred to residential treatment via community care network are mostly only able to access programs that are physically located within their respective jurisdictions, each of which is managed by either OptumServe or TriWest. Arbitrarily restricting the program access based on administrative network boundaries limits VA's ability to coordinate timely and appropriate residential mental health and substance abuse care for veterans. Chairman Tester, Ranking Member Moran, this concludes my testimony, and I'm prepared to answer any questions you may have. Thank you.
Thank you for your testimony, Megan. I appreciate it. It's always good to have VFW's perspective here. Next, we have Jim Lorraine, who is the President and CEO of America Warrior Partnership. The floor is yours, Jim.
Chairman Tester, Ranking Member Moran, and members of the committee, thank you for the opportunity to testify before you today. For nearly a decade, community care has grown in veteran preference and size. Its positive impact for the veterans community has been extraordinarily important and life-saving. Access to community care is critical to America's Warrior Partnership and our rural community programs where we advocate for veterans and their families. The VA Secretary testified last year that the community care had grown so successfully that the cost may require limiting its growth. It's troubling that when the VA has a successful community care program that is working, the instinct is to trim it back. A small number of individuals and organizations believe that if veterans are given the choice or allowed to manage their own care, the VA will cease to function. In fact, it is the contrary. Ensuring the VA has strong, effective community partnerships helps safeguard the VA's healthcare system and keeps it strong for future generations of veterans. We have seen veteran enrollees increase as the door to community care opens, as veterans return to the VA to get care. But important elements of the community care must be made permanent, including access standards. Mission Roll Call conducted a series of poll questions on these issues with over 6,300 veterans' responses across the United States. Over 81% said Congress should codify the community access standards. 71% said they were not referred to a community care after a delay in mental health or other specialty care at a VA facility. This clearly indicates a problem. The VA must not only provide community care, but actively educate veterans that they have a choice. Accordingly, AWP was proud to support the access standards 2 years ago when introduced by Ranking Member Moran, and again proud to support the Health Act introduced by Ranking Member Moran and Senator Sinema. The Health Act codifies the access standards and applies them to nearly all types of care. It also addresses the unacceptable practice of restarting the wait clock when the VA cancels or reschedules an appointment or refers to a telemedicine appointment instead. Chairman Tester, AWP supports making community care work legislation, which is similar to the Health Act in many ways. In fact, we support that this bill creates a program for veterans to begin self-referral for some services, such as vaccinations, vision, or other hearing services, but feels substance abuse and mental health should be added to the self-referral program. And I would argue that what the VFW said, it's much further that should be included also. AWP recommends including provisions for value-based care already used by Medicare to advance the quadruple aim of providing better care to individuals, improving population health management strategies, improving the work quality of healthcare providers, and reducing healthcare costs. Along these lines, as a nurse and a leader, I strongly encourage the committee to consider continuity of care, which has been repeatedly documented to improve outcomes as a measure of criteria equal to the time and distance of an appointment. AWP hopes this committee can compromise on the best of both of these proposals and pass the legislation quickly. Chairman Tester and Senator Bozeman, regarding the Not Just a Number Act, AWP is supportive of the intent of the legislation. However, the suicide and premature non-natural death is too complex for one perspective, and this committee should request an outside view related to VA reporting. We suggest this committee request transparency, not necessarily additional data. In fact, the data requested in the legislation is exactly what's missing from Operation Deep Dive, and we look forward to working with the VA in the future to fill that gap. We're very grateful for the inclusion of some of the Operation Deep Dive interim summary recommendations in this legislation, providing a tool for coroners and state medical officials to help verify veteran status quickly and accurately, and evaluating the VA Suicide Prevention Office to the Secretary level is long overdue. Again, thank you for the opportunity, sir.
Thank you for your testimony, Jim. I appreciate it. I am going to use my privilege as chairman of this committee to turn it over to the old timer on this committee, Senator Murray.
The youngest old-timer ever. Thank you so much, Mr. Chairman, and thank you to all the committee members. Really appreciate your holding this hearing to look at some of the really important legislation coming before this committee, including the EHR Program Reset Act, which we introduced earlier this year with Senator Brown. I, as you know, have been raising concerns about VA's implementation of EHR from the start. And when I say start, I mean before the ink was even dry and the contract between Oracle Center and the Trump administration was signed. And the criteria for success is pretty straightforward to me. Does it work for our providers? Does it work for our patients? Are we helping veterans get the care that they deserve? Which is what I'm focused on when I talk to our veterans back in Spokane and Walla Walla. Unfortunately, it was pretty clear early on that this new system was missing that mark in a lot of ways, whether it's the providers in Spokane who are really burnt out just trying to navigate the broken interface, or the patients who are unable to get the medicine they rely on because of the system malfunctions. And as we all know, a flawed system can be fatal, and I have previously discussed here about a constituent of mine who received a late cancer diagnosis because the system didn't work the way it was supposed to. So it is painfully, devastating clear to me this system has been not working for our veterans or our providers and was broken. So the reset VA announced this year was really badly needed, but we do need more than a reset. We need reforms that make sure the problems with the EHR are not just fixed, but don't ever happen again in the future. Many of those problems stem from the deeply flawed single source contract the Trump administration agreed to back in 2018. I think we should all agree on that. And regardless, we should be doing everything we possibly can to make sure we have a VA where veterans can get the highest quality of care they deserve. So I look forward to our witnesses and appreciate all of you being here. And let me just start for the whole panel and ask you, what gaps do you see in VA's current contracting process, and what else can VA be doing to make sure that in the future it does not face the same issues that we had with this contract?
You get to go first, John.
Yeah.
Thank you, Senator. A great question, and obviously the EHR, we also resonate your concern. DAV is quite concerned with the progress of where EHR was and the safety issues that were brought up. With regards to the contract, DAV's position is that we feel very strongly that our veterans deserve a modernization to ensure that they have the resources that are there to apply quality health issues and needs. But at the same time, we want to ensure the providers have that infrastructure that works for them to provide safe care. With regards to now the contract, DAV does not have a position where we care who has that contract as long as the contract and the VA's relationship of governance over that contract has the authority to ensure that they're doing it right and that they're overseeing with good, strong oversight to ensure VA is held accountable, and so is the contract being accountable to fulfilling the contract and its obligations to the veterans, taxpayers, and this nation. So that's where we're sitting at this time, is we just want to ensure that VA knows what they're doing and does it with the right partners that will get it done for them.
Ms. Thomas, Mr. Lorraine, do you have any comments about the contracting process?
Good afternoon. At this time, I do not have any comments in regards to the contracting.
Mr. Lorraine?
Yes, ma'am. In terms of the contracting, I don't have comments, but I would echo what DAV is saying, that it's critical that we have to get it done. I served on a senior oversight committee at the Department of Defense back in 2008, and this was an issue then. It was in 2008, and it needs to get done. I'm a victim of it myself, and it needs to get fixed.
Okay, thank you. And let me quickly ask about the Expanding Veterans Options for Long-Term Care Act. Our population of veterans is aging, and we have to make sure that there are long-term care options available for them. So that's exactly why I joined Chair Tester and Ranking Member Moran in introducing the bipartisan Expanding Veterans Options for Long-Term Care Act, creating a pilot program for our veterans to get assisted living care. Just real quickly, any of you, can you talk a little bit about what some of our veterans are facing in our rural areas in terms of long-term care? Ms. Thomas?
Thank you for that question. So when we're dealing with long-term care options, especially in the rural area, we already have limited access to care. We actually see this program, this pilot, as a good opportunity to provide the care that it's like that middle care. They're not sick enough for nursing home care and are not able to be on their own. I believe this opportunity for assisted living in rural areas would actually allow for the veterans to get the care they need without having to worry about the financial burden. And I think that's one of the biggest factors that we need to look at.
Okay. The chairman's been generous allowing me to speak in an amount of time, but if any of you could give me written comments back, I would really appreciate it. Thank you.
Thank you, Senator Murray. Senator Moran.
Chairman, thank you. Mr. Thomas, I'm grateful to you for your support of the Veterans Health Act, and I'm glad to have VFW and a diverse group of growing VSOs and other veteran service not-profits supporting this legislation. Can you elaborate on why the VFW supports Veterans Health Act and how enacting it would align, not compete, with the VA's efforts to focus on improving wait times, embracing whole health, and preventing suicide?
Thank you for that question. The VFW definitely supports improving community care. We understand that patient-centered care should be a priority. Value-based care focuses on prevention, which reduces illness and suicide, which is the top priority for all of us. I would have to say that one section that we were looking into is Section 103 to clarify the best interest and veterans' preference versus the veterans' preference. We want to ensure that we're not pushing all veterans to go outside the care of the VA, which VA provides better than most outside areas.
Mr. Lorraine and Ms. Thomas, the VA opposes Section 103 that was just mentioned of the Veterans Health Act, which would require the VA's criteria on how a veteran and their provider can reach mutual decision about a veteran's best medical interest to include the consideration of a veteran's preference. So what I'm saying is that the VA opposes the consideration of what the veteran believes he or she is in what they want to see. To be clear, this section does not stipulate that a veteran's preference is the outcome of the decision. This section would not stipulate that a veteran is entitled to care in the community just because they express a preference for it, nor would it alter the current statutory requirement put in the Mission Act that best medical interest be determined between the veteran and their clinician. As you know, healthcare is a highly personal issue. Why do you think it's important that decisions about a veteran's care take into account personal preference for when, where, and how they seek care? Mr. Lorraine?
Thank you for the question. I think when it comes to health care, it's a personal choice. And I think because you're a veteran, you shouldn't have your choices forgone. You should have a say in the health care that you receive and where you receive it, no matter where you live in the country. And I think your point and the point of between the physician and the patient has to be the decision. It can't be a bureaucratic decision that breaks the 30 days, that breaks the distance, that breaks all the continuity. It needs to be between the physician and the patient. Thanks.
Thank you. And let me ask just a broader question about this topic. Mr. Retzer, I understand the DAV's concern about preserving the primary role that the VA plays in providing and coordinating care for veterans who are enrolled in the VA healthcare system. To that end, Senator Tester and I perhaps join forces to craft a compromise bill that draws on the best of both of our separate bills. Would DAV support the inclusion of language reasserting that role for the VA, even as access is expanded under certain circumstances into the community?
Thank you, Senator, for asking that question. And where DAV stands with this is we appreciate both the bills, and we have provisions that we appreciate and we understand where it's coming from, especially to try to address your constituents' needs in Kansas and Montana. You have very dynamic in Kansas dynamic populations that are very sparse, and that VA does not have the infrastructure to support that population, let alone Montana. Not only do we have that same situation, but geographical constraints that hurt that situation, along with the individual veterans' preference issues that may cause them not to. Now, we definitely invite, just as we had said in our testimony and also in my oral statement, I would welcome the opportunity to work with you and your staff to draw a nice piece of legislation that's bipartisan, and I think we can get there. We do understand what your intent is, and we just don't want to take away the authority from the VA as a primary, because one of the concerns that we have with the VA is that they provide so many significant wraparound services. Like myself, I use the VA healthcare system 100%. I'm very fortunate to be 25 miles from DC and 25 miles from Baltimore, but you also know that navigating Baltimore and DC is not always easy. So there will be veterans who cannot do that. So that would be maybe a foreseeable reason that's realistic. But then there's also, I have the fortunateness of having a CBOC, not like your constituents. They may not have either of them. So we do understand, and we did support the Mission Act, and we did support the Community Care Program. We just want to ensure that when we look at legislation, it's very well thought out, and we think there's a special need for our rural veterans that are in a very unique situation.
John, my intent of that question was to suggest to you that I might be willing to again reassert. I was fully engaged in the Mission Act, so the language that's in there is language that I've participated in creating and language that I voted for and support. And my point in asking that question is that I may be willing to reassert that role for the VA, but there still may be instances in which, in my view, we need to expand access to community care. Does that trouble you?
We understand that initially when the Mission Act was looked at and we were compromising and looking at crafting it, the terminology of supplement versus supplant. And we want to continue to supplement the community care. We know it's needed, and the VA system is weakened and is struggling. And that's why we want the investments, and both you have provided, legislation to strengthen the VA's infrastructure. So we think that just putting everything together and working together and discussing the provisions that we have concerns and how to clean it up a little bit easier for our veteran community to make a seamless system so that they're not navigating a bureaucracy or they're not navigating red tape, but it gives authority to the secretary to do the right things when the time is needed. We really do want that warm handoff for our veteran community, because the fact is our veterans, typically, if I go to general care and community care, I have more than 5 issues that general physician has to deal with. That physician may only be able to identify one issue or address one issue. Then they want me to do a lab or some reference. Now there's more referrals. So that's why we want to ensure the best medical practices and the best medical interests are applied accordingly.
John, Megan, and Jim, thank you.
Senator Blumenthal.
Thanks very much, Mr. Chairman. Thank you for being here today. Ms. Thomas, you've had very extensive experience as a caregiver, as a medic, and also as a caseworker. So I would like to ask you about a problem which may not be reflected extensively in the legislation. There is one piece of legislation dealing with veteran suicide, but perhaps you could give us your assessment as to what more we can and should be doing, we meaning not only the VA, but also Congress. Like others on the committee, I've worked extensively for legislation, for more resources, been critical of past VA administrations because of the failure to do more outreach, for example, using the resources that have been available. But maybe you could talk a little bit about veteran suicide and what we ought to be doing.
Thank you for that, sir. So one of the things that the VFW looks at, identifying, and I'm going to just speak a little bit on Senator Tester's bill, but not just the number act. We understand that the data that's received from the VBA is important. We know it coincides because it's not one instance, one thing that causes suicide. Having food to eat, having a roof over your head, having money in your pocket, having a job are factors. And if those factors are not, those needs are not met, that puts a person in a position to want to commit suicide. This actually brings me back to prevention methods that could be used. We actually currently have one that we could actually be using right now. And I just wanted to just highlight the TAP program. TAP program is actually given for service members who are exiting out of the service. We need accredited service representatives to actually assist those with filing claims. We need those services, that TAP program, to actually talk about educational benefits, talks about housing options, talks about things that they're going to need to be able to get out so they won't be able to walk out of the military and have nothing to look at. So I think really looking into the TAP program and how we better enhance the TAP program and how we make sure that our service members are being able to utilize that program is going to be key for what we need to do going forward in the veteran realm.
Would you recommend any particular legislative initiatives to that end?
I would recommend not just a numbers act. I think the VBA data is essential to get a whole view on barriers that could lead to suicide.
I noticed that in your testimony, Senate 1040, prohibiting smoking on the premises of any veterans facility, VHA facility, you recommend against our approving. Could you explain a little bit more why you're against prohibiting smoking on VA facilities? I know that you say that having a specific area where smoking may be permitted is a middle ground, but it would seem to me that smoking is certainly a detriment to health, and permitting it anywhere on a VA facility sends a message of acceptability that the VA ought to avoid. Do you differ?
So with that being said, sir, and thank you for that, the VFW understands that there are barriers out there. What we do not want to see is a barrier we don't want to see smoking as a barrier for veterans not going to get the care that they need. Also, we're even looking at the staff that works at the facilities. If they can't smoke, they may not want to work there. The VA is already behind when it comes to employment. So we don't want to have any barriers, and that's the reason why we're choosing against the bill.
Thank you. I don't know the answer to this question. Maybe some of you do. Does the VA have smoking cessation programs as part of what it offers? I'm seeing some heads nodding. I haven't asked this question before, so forgive my ignorance. And how widely are they offered? To any member of the panel.
From personal experience, every time I go to the VA, I'm asked whether I smoke or whether I consume alcohol, and they always have a program that's available. It's literature in the pamphlets and whatnot. There's a number of programs in the facility in Augusta that I attend.
I'm wondering how strongly they urge or recommend these programs beyond saying it's available.
I can just speak to my experience, but additionally, Senator Blumenthal, with our Operation Deep Dive study, we have also seen not just non-natural deaths, but we see natural death and a differentiation amongst cancer-related, that would be lung cancer-related premature early deaths amongst veterans. It's not a bad thing to stop smoking.
Thank you all for being here. Thanks, Mr. Chairman.
Senator Sinema.
Thank you, Chairman Tester, for holding this hearing, and thank you to our witnesses for being here today. With over 500,000 veterans calling Arizona home, conversations around accessibility of veteran-specific health care are critical to ensuring the welfare of our state. Access to veteran health care services in rural areas is often limited, and it's necessary to come up with ways to keep our veterans from going without services simply because they can't reach the facilities that are able to provide them with care. In circumstances where non-VA emergency medical care results in saving these veterans' lives, they shouldn't have to jump through hoops to get reimbursed. And that's why I, with Senator Braun, introduced the Relieve Act to expand the eligibility for veterans to access emergency care from a provider outside the VA. I've also joined with Senator Moran, our ranking member, in introducing the Health Act to ensure Arizona veterans retain the ability to make their own decisions around their health care, while also making much-needed improvements to the quality of care provided. and I look forward to working with both Senator Moran and Chairman Tester to continue to improve options for community care. My first question is for you, Ms. Thomas. Nearly every day, my staff helps Arizona veterans navigate an unexpected VA medical bill. What efforts should the VA implement to ensure that staff and community emergency departments are aware of the new eligibility criteria to prevent the veteran from experiencing issues or reimbursement delays? And do you believe legislation like the Relieve Act will help address the problem?
I do believe, thank you for the question. I do believe that the legislation, the Relief Act legislation will definitely impact those veterans, definitely understanding that when a veteran needs to be able to receive emergency care, they need to receive emergency care. It shouldn't be, they should not be burdened by the fact that they didn't get their initial visit at the VA to get that care.
Thank you. Mr. Retzer, Arizona has many veterans living in geographically isolated areas like Show Low or Pine Top, where it can be harder to access care due to the lack of community providers or outreach or communication. Have your organizations raised similar concerns with the VA to ensure that these veterans are informed of their eligibility and have access to the care that they've earned?
Senator, thank you for that question. That is actually a question that is asked to our national service officers out in the field. That's one of the things that I spent 14 years advocating out there and spent 20 years with the DEV trying to navigate this issue and trying to influence VA to ensure that they're doing proper training of their patient advocates, their staff, and to ensure that they're sharing that education and knowledge to the veterans on what they're eligible for. So when we look at VA's infrastructure, it is very difficult for them. So we continue to speak with the VA and collaborate with them to where their shortcomings are, where there's more improvements to improve the veterans' experience in both the benefit side and the health side.
And as a follow-up, what steps could the organizations here today or our congressional offices take to ensure that veterans in Native American communities, for us particularly the Navajo Nation, receive either the same or better outreach?
Thank you for that question, too. And I think one of the things that we're seeing in the legislation here is very thoughtful in the way that we're looking at for our rural veterans or veterans in remote areas. And it comes with collaborating with the VA to do outreach. For example, the direct health care system of having direct connect to our homeless veterans, for example, could be the same application to our Native Americans who are needing those assistance, who have those barriers, and who may also have some issues or cultural issues with, working with the VA system. So we need to be able to ensure that we open the doors and start to communicate and show the communities what they are entitled to and make a warm entrance into it by making sure we have partners on both sides that are being trained equally the same way and that understand the system.
Thank you. Mr. Lorraine, my office also hears from Arizona's veterans about the cumbersome community care referral process, which can negatively impact continuity of care. One issue my Health Act bill is trying to address is to ensure that veterans who are seeking mental health care or treatments for substance abuse can self-refer to get the help they need when they need it. What improvements to the referral process should be made to make it work better, and of course, without delay for patients and caregivers?
Yeah, I think, especially those two areas that you just talked about, they're stigma-ridden. And I think if the veteran can have the ability to directly seek out care for whether it's mental health or substance abuse, that's important. America's Warrior Partnership, one of our programs is the Nine Nazba Partnership. It's Navajo women veterans that are employed by us that work up in Show Low. They're up in Chimney Rock or Window Rock and Shiprock.
Yeah.
We see it all the time. We see it, hear it from them. Their goal is to go find and develop a relationship with veterans. Their biggest issue is that there's facilities that are local that they could use, but there is no way, there is no mechanism to go use those. They have to either go to Gallup, as you know, or go down to Phoenix, which is a pretty arduous trip. So we have, between the Alaska Warrior Partnership and our work in the Navajo Nation, we have extensive experience. I would just also, and I know I'm running over, I would also say that the thought that we're going to call these veterans when they don't have, they barely have electricity, they barely have water, and a phone is something that's far beyond that. I think that it's a personal relationship, especially within the culture of the Navajo.
Yeah. Thank you. Thank you all for taking the time to be here today, and my team is going to continue working with all of you. Mr. Chairman, thank you for the hearing.
You bet. Thank you. Senator Murray brought up expanding veterans' option for long-term care act, a bill that I've got, and she talked about the number of veterans who are over the age of 85. I think it's going to increase by over 500% in the next 20 years. Right now, the VA is prevented from paying veterans to receive assisted living services. This bill would help address that. For you, Mr. Retzer, can you explain how allowing the VA to pay for assisted living would help address the needs of this growing population?
Thank you, Chairman Tester. Well, DAV, we actually support this piece of legislation. We really appreciate the thoughtfulness of expanding options. So not just for our long-term care, but our seriously injured veterans. As you know, we see that even our younger veterans who have serious injuries or illnesses, they do need care that extends beyond the skilled nursing care. So we appreciate the fact that there's a piece of legislation here that would create a little bit of seamlessness for a veteran who needs that extra care to be able to have VA provide that resource.
I'm going to stick with you, John. The CHARGE Act makes permanent certain essential programs that expired in May. It's also a bill that I've authored. These programs serve homeless veterans and caregivers who would assist state veterans homes dealing with staffing shortages. Does DAV support this legislation?
Yes, we do, and this is a very thoughtful piece of legislation to address the safety and survival issues and needs of our homeless veterans, and we definitely support the issue of having direct services with our homeless veterans to provide not only the survival items of food, shelter, and clothing, but to also extend that service to the transportation of medical appointments, and also then keeping them connected with technologies like tablets or even mobile phones.
You answered my second question. Last year, the VFW came to our committee with the idea to make VA's annual veteran suicide prevention report go beyond just health care, so we could better understand what we can do to help prevent veteran suicide. Senator Bozeman and I have the Not Just a Number Act to require the VA to make more comprehensive look at veteran suicide, including the use of VA benefits. For Ms. Thomas, can you speak to the importance of this bill for VFW and how it would be useful in improving veterans' suicide prevention efforts?
Thank you, sir. So this bill would allow from VBA's data to be used in regards to making, in regards to identifying the barriers that causes suicide. The additional data going into the annual VA report would actually provide some clarity and actually start conversations about what preventive methods can we use to actually help the veterans to limit their chances of wanting to commit suicide.
Secretary Elna Hall was in front of this committee before the 4th of July break and talked about self-referral as a potential option that he's working on, which I see some real potential for. Dr. Senator Cassidy brought up the point of oversubscribing, and how do you prevent that? Our community care went up by a little over $5 billion with a B last year as far as the budget line item. Look, Senator Moran and myself come from places where health care is hard to find if you're in the VA, or if you're not in the VA, it's hard to find. So giving these folks the ability to go out and get health care is really important in the community. You don't want them driving 100 miles, and the nearest big hospital to me, and I actually live in a place that's not the end of the earth, is 75 miles, so a 150-mile round trip. But the oversubscription issue is not something that we've talked about a lot. How do we control that? Assuming there's going to be some, and you can live with some, but how do we control that? Anybody can answer that question if you have a thought. Jim, go ahead. You haven't spoken yet, so.
No problem, sir.
At least not my question.
Yeah, so, you know, as a healthcare provider, I would tell you that oversubscription, you're going to get it. But I think that the point of sale or the point of dispensary is probably the best place to address oversubscription. The pharmacies are linked.
Oversubscription, and maybe I used the wrong word.
Yeah, maybe.
From a healthcare standpoint. So somebody has a sprained finger, really does need to be looked at, but what the hell, it's free, so I'm going to go do it.
Right. You know, I think in terms of So overuse of the.
Yeah,
of
overuse
that-
of the system
of the
overall.
system.
Not only
Got it.
subscriptions, but, not only prescriptions, but overall use. Yeah, sorry, I should have made that.
No problem. I think, as I said, I think in terms of reducing that oversubscription, you're going to have it whether it's in the VA or whether it's in the civilian community. The civilian community on the billing, you're going to see it. And I think it's something that you address on a case-by-case basis. I always say that 90% of the rules are meant for 10% of the people.
That's a fact.
And there's probably a group of people that are going to overuse it, but I would rather address that than take it away from the 90%.
I don't think it's the intent of anybody on this committee, and I don't want to speak for everybody, that we're going to take away community care by any stretch of the imagination. But it's a pitfall that I never thought about. Cassidy is a doctor. He's probably seen it. That's why he brought it up. So, and I appreciate it. I want to thank you all for being here. I appreciate your perspective. I want to apologize to the first panel. Hopefully they're still here for missing theirs. I had a water compact in Indian Affairs that I had that we've been working on for 12 years, actually longer than that, that I had to introduce. So that's my excuse. But thank you all for being here. Look, we're going to continue to work together to figure out ways we can get health care to our veterans in the best way so that we keep them healthy forever, because they've earned that. Thank you all very much.